The infectious disease community has been witnessing a significant rise in multi-drug-resistant gram-negative organisms. For example, pathogens that produce multiple resistance mechanisms such as extended-spectrum beta-lactamases, or ESBLs, have developed resistance to many later-generation antibiotics, including the beta-lactams, one of the most commonly used antibiotic families. Newly emergent Klebsiella pneumoniae carbapenemases, or KPCs, present an additional challenge. Vabomere is specifically designed to protect the activity of meropenem. Vabomere combines the well-established utility of meropenem, a beta-lactam in the carbapenem class, with vaborbactam, a specifically designed beta-lactamase inhibitor, or BLI, the first in a new class. Meropenem is proven to work against a broad spectrum of gram-negative pathogens. As a carbapenem, meropenem has a bactericidal effect on pathogens and prevents their growth and replication. This occurs when the beta-lactam ring binds with and inactivates multiple types of penicillin-binding proteins, or PBPs, disrupting bacterial cell wall synthesis, which leads to cell rupture and destruction. But pathogens are known to develop resistance mechanisms against the beta-lactam antibiotics. Beta-lactamases, especially ESBLs, can hydrolyze many beta-lactams and inactivate them. Meropenem can work even in the presence of ESBLs. It is stable to hydrolysis by most beta-lactamases, including ESBLs. However, meropenem can be hydrolyzed by the carbapenemases made by KPC-producing bacteria. Carbapenemases are beta-lactamases that can contribute to one of the most urgent threats of antimicrobial resistance in the US and several other parts of the world. Vaborbactam was specifically designed to target KPCs. Vaborbactam is a tight-binding cyclic boronic acid BLI. Its potent inhibitory action protects meropenem from degradation, including KPCs as well as other beta-lactamases and ESBLs. Vaborbactam displays high activity against KPCs and inactivates KPCs. The pharmacokinetic profiles of meropenem and vaborbactam are comparable, which results in similar patterns of concentration and elimination. Inside the bacterial cell, vaborbactam protects meropenem from beta-lactamase inactivation, including from KPCs. Vaborbactam preserves meropenem activity against KPC-producing strains, reducing MIC90 from 32 for meropenem alone to 1 in combination, which was demonstrated against KPC-producing isolates of Enterobacteriaceae. Meropenem is free to disrupt cell wall synthesis, which leads to cell rupture and destruction. The meropenem-vaborbactam combination in Vabomere demonstrates a bactericidal effect against designated susceptible gram-negative organisms, including certain ESBL-producing and recently emergent KPC-producing pathogens. Indications and usage. Vabomere, meropenem, and vaborbactam is indicated for the treatment of patients 18 years of age and older with complicated urinary tract infections, CUTI, including pyelonephritis caused by the following susceptible microorganisms: Escherichia coli, Klebsiella pneumoniae, and Enterobacter cloacae species complex. To reduce the development of drug-resistant bacteria and maintain the effectiveness of Vabomere and other antibacterial drugs, Vabomere should be used only to treat or prevent infections that are proven or strongly suspected to be caused by susceptible bacteria. Contraindications. Vabomere is contraindicated in patients with known hypersensitivity to any components of Vabomere, meropenem and vaborbactam, or to other drugs in the same class, or in patients who have demonstrated anaphylactic reactions to beta-lactam antibacterial drugs. Warnings and precautions. Hypersensitivity reactions were reported in patients treated with Vabomere in the clinical trials. Serious and occasionally fatal hypersensitivity, anaphylactic reactions, and serious skin reactions have been reported in patients receiving therapy with beta-lactam antibacterial drugs. There have been reports of individuals with a history of penicillin hypersensitivity who have experienced severe hypersensitivity reactions when treated with another beta-lactam antibacterial drug. If an allergic reaction to Vabomere occurs, discontinue the drug immediately. Seizures and other adverse central nervous system CNS experiences have been reported during treatment with meropenem, which is a component of Vabomere. Close adherence to the recommended dosage regimens is urged, especially in patients with known factors that predispose to convulsive activity.
Clostridioides
Difficile-associated diarrhea, CDAD, has been reported with the use of nearly all antibacterial agents, including Vabomere, and may range in severity from mild diarrhea to fatal colitis. Careful medical history is necessary since CDAD has been reported to occur over 2 months after the administration of antibacterial agents. If CDAD is suspected or confirmed, ongoing antibacterial drug use not directed against C. difficile may need to be discontinued. The concomitant use of Vabomere and valproic acid or divalproex sodium is generally not recommended. Case reports in the literature have shown that co-administration of carbapenems, including meropenem, to patients receiving valproic acid or divalproex sodium results in a reduction in valproic acid concentrations. The valproic acid concentrations may drop below the therapeutic range as a result of this interaction, therefore increasing the risk of breakthrough seizures. If administration of Vabomere is necessary, consider supplemental anticonvulsant therapy. In patients with renal impairment, thrombocytopenia has been observed in patients treated with meropenem, but no clinical bleeding has been reported. Alert patients receiving Vabomere on an outpatient basis regarding adverse reactions, such as seizures, delirium, headaches, and/or paresthesias that could interfere with mental alertness and/or cause motor impairment. Prescribing Vabomere in the absence of a proven or strongly suspected bacterial infection is unlikely to provide benefit to the patient and increases the risk of drug-resistant bacteria. As with other antibacterial drugs, prolonged use of Vabomere may result in overgrowth of non-susceptible organisms. Adverse reactions. The most frequently reported adverse reactions occurring in 3% or more of patients treated with Vabomere were headache, phlebitis infusion site reactions, and diarrhea.